Professor Magdy, one of the eminent professors in Egypt and known as well as a UK surgeon. He specialized in the head and neck surgery. Again, I cannot thank you for thanking you for the acceptance of this to give us this nice talk. It's one of the most problematic things that when we face a patient with functional dysphagia and we don't know how to assess and what to do. So I will give the mic again to Professor Magdy. Sir?
Hello, everyone. Can you hear me well?
Yes, sir.
Fine. Just trying to start this now. Okay. Right. I'm starting this presentation on the assessment of pharyngeal functional dysphagia. Can you see the presentation on the screen?
Yes, sir. Yes.
Yeah. Right. So that's just. What I'll try to go through in this presentation is a little bit on the pathophysiology of the swallowing, of the act of swallowing, and this would help in identifying how can things go wrong with the swallowing. And then we'll go through the self-assessment tests by the patient, the clinical tests, a bedside test or in the clinic for dysphagia and aspiration, followed by the FEES, the fiber optic endoscopic examination of the swallowing, and then the use of the video fluoroscopy in the grading of the dysphagia and in the grading of aspiration, two different grading systems that we're going to use. So start with this, how common is pharyngeal dysphagia? Pretty common in fact, and the act of swallowing is very well controlled by several neural centers and several muscles. And it's easy to see how things can go wrong if there is a problem with the central nervous system or problems in the neck or problems in the larynx or the pharynx. Like 30% of patients who had a CVA would have difficulty with swallowing or aspiration. Again, maybe about more than 50% of patients with Parkinson's will have the same, 80% of patients who have Alzheimer. A lot of patients who are elderly patients would also have one degree or another of dysphagia. And if the elderly are in a care home or so, the rate is much higher. And that's general causes for the central nervous system. But in addition to this, almost more than 2/3 of patients who have tracheostomy would have some degree of dysphagia. 2/3 of patients who have head and neck tumors would also have dysphagia. Quite a number of patients who have gastroesophageal reflux, and also patients who had a recent general anesthetic. Now, this is just to go quickly through some of the normal values for video fluoroscopy and manometry. The whole act of swallowing, of pharyngeal swallowing, should take about 1 second, plus or minus maybe 0.20 of a second. This is the timeline of how we swallow, and it all starts with the opening of the glossopalatal junction, the contact of the base of the tongue with the palate. And almost immediately, this is going to be followed by closure of the velopharyngeal function. And this should take at the same time, the pharynx and part of the larynx are reconfiguring to allow for the bolus to come in and be passed safely. Now, for this one in there, it may take a fraction of a second, 0.1 to 0.20, depending on the bolus itself, the volume and the texture. If it is less than 10 milliliter of a fluid, it shouldn't take any time. If it is more, then it may take a little bit more. And then 0.6 of a second will be spent doing all the other activities. Like larynx would, the larynx would elevate and rotate forwards, and this is going to open up the upper esophageal sphincter. There will also be a closure of the laryngeal vestibule and closure at the glottic level. So this, all these actions should take a second in order for the bolus to pass the hypopharynx and for the larynx to resume its respiratory function promptly. Now, to do this, you need to generate pressure. And the maximum pressure that can be generated would be from here, from the base of the tongue thrust, which could generate something around 130 millimeters of mercury or so. This is almost double the pressure that can be generated by the pharynx itself, pharyngeal muscles, the superior, middle, and inferior constrictors. This amount of pressure would push the bolus very quickly, like with a rate of 4 centimeters in a second through the hypopharynx. In order to exit the hypopharynx, the upper esophageal sphincter would have to relax. The resting pressure of the upper esophageal sphincter is quite high. It's about 90 plus or minus 30 millimeters mercury. So in a resting stage, it wouldn't allow some or even most of the bolus to pass. It had to relax. And when it relaxes, the pressure would drop remarkably down, somewhere around 10 millimeters, 0 millimeters, or sometimes negative pressure in the area. But if there is a spasm in the muscle, the pressure could be up to 240 millimeters mercury. This was not going to allow any bolus to pass. The relaxation period, the duration itself, should take just more than a second, 1.5 seconds plus or minus. So this is how we normally swallow. Very well-coordinated acts that generate pressures and relaxation in certain areas, and the bolus which have to be a sweep of the hypopharynx without spilling up the nasopharynx or the oropharynx or spilling down into the larynx. This is just to show how the things go wrong. The normal pressure that is going to open up the upper esophageal sphincter is here in normal controls. Somewhere in the x-axis, you would see the area of the upper esophageal sphincter opening, and on the y-axis, you would see the pressure needed to affect this opening. So with a pressure between 10 and 20 millimeters mercury, you could open up the upper esophageal sphincter to 150 millimeters square. This translates to about a diameter of about 14 or 15 millimeters. But if things are, if there is, for example, a cricopharyngeal spasm, or if there is a Zenker's diverticulum, then a much higher pressure would be needed to open up the sphincter. And again, it would only open it up for a very limited area. You see how the curve for the Zenker's diverticulum is much steeper than the curve for normal individuals, and how this curve can be corrected by cricopharyngeal myotomy. This is going to bring back the curve to the normal limits. Something is not getting. How can things go wrong if there is a problem, a central problem like a stroke, effect of age, radiotherapy, smoking, various neurological and muscular dystrophies? or local factors affecting the pharynx or the larynx or the tongue or the hyoid, or having a tracheostomy. All these can affect the act of pharyngeal swallowing. So looking into them a little bit more closer, these are the tongue factors that would affect the swallowing. The major pressure generation act here is this: the base of the tongue in contact with the palate would push the bolus with a pressure of about 130 millimeters mercury down. If there is a problem in the muscles of the pharynx, of the tongue, if there is a problem with the hyoid, for example, if there is a problem with the suprahyoid muscles that pulls the hyoid upwards, or if there is a problem in coordinating the muscle actions of the tongue, then there will be a problem with the dysphagia. And of course, if there's, I've missed one. If there is a problem in the larynx, the same would happen as well. Things like incomplete glottic closure, if there is a problem in the sensation of the larynx, if there is paralysis of the vocal folds, if there is a very short duration of the adduction, it cannot maintain itself, if there is a reduced elevation of the larynx and reduced anterior rotation during the act of swallowing, this is also going to affect the swallowing, the act of swallowing. And yeah. And of course, hyoid factors are going to impact the tongue mobility and the tongue thrust and the coordination of the muscles of the tongue and the upper part of the neck. The hyoid bone needs to move upwards and forwards in order to pull the larynx and open up the upper esophageal sphincter. And if this fails due to a problem in the hyoid muscles, then the upper esophageal sphincter would not open. And then the cricopharyngeus sphincter itself. The cricopharyngeus opening is actually a two-phase process. The cricopharyngeus muscle itself would have to relax to drop the pressure from 90 millimeters to about 10 millimeters or so. So it has to relax first before the bolus approaches the area. And when it relaxes, 0.1 second before the bolus arrives, then the bolus can pass this segment with the pressure generated by the tongue and the other parts of the pharynx. But the second part of this process is the opening of the muscle itself, the cricopharyngeus muscle, by the upward and the forward pull on the muscle with the movement of the larynx. When the larynx elevates upwards and forwards, it pulls the anterior part of the muscle and opens the upper esophageal sphincter widely. If this does not happen, like in this case, you could see how the dye is pooling in the piriform fossae, piriform sinus in here, because even though the cricopharyngeus could be relaxed, it's not open because the larynx is not moving. This patient has learned to pull his larynx manually in order to pull his larynx upwards and open up the muscle. And then tracheostomy. Tracheostomy, more than 2/3 of the patients who have tracheostomy would have a degree of dysphagia or aspiration. This is due to the loss of the normal phase of the glottis adduction, the impairment of the glottic closure, the decreased laryngeal elevation due to the fixation of the larynx and the lower part of the neck, the ineffective cough, and the reduced glottic reflexes. Tracheostomy is not really a good treatment for dysphagia and aspiration, although we'll be asked often to do tracheostomy for patients who aspirate. By doing this, we only buy a little bit of time in order to clear the chest and prevent accumulation of the aspirate down the chest. We were not helping the act of swallowing by doing a tracheostomy. Yeah. Now to the clinical tests to assess the dysphagia and aspiration, starting with the patient's-based questionnaire, eating assessment tool, 10, and the Sydney Swallow questionnaire, followed by 8 different tests, a bedside test. Most of them would entail drinking a certain amount of water within a certain time limit and watching for any signs of respiratory distress or coughing or choking or a change in the pulse oximetry, followed by tests that can be done in the intensive care for patients with tracheostomy, for example. These with 3 last tests can be done in the intensive care, even in comatose patients. So this is the first thing to do, is assess dysphagia, the eating assessment tool, EAT-10, and it's a 10 different questions. The patient would score from 0 to 4, where 4 is severe problem, for things like if there is any problem with swallowing, any efforts in swallowing fluids and thick fluids or solids, or any history of aspiration, swallowing is painful, different things, these 10 questions. And if the patient scores anything around 3, he shouldn't get, it's very easy to get 3 out of these 10 questions, because you can actually score 4 for a severe problem in any of these aspects, but anything 3 or above would alert the physician that there may be a problem here. It's a screening tool, that there may be a problem here that requires further attention, like having a flexible endoscopic examination of the swallowing, for example. Now, the E-test has been validated, and it's a reliable way of measuring dysphagia, assessing the functional dysphagia. You could see that normal individuals would score very low in here, below something just around 3. But if you have problems with reflux, if you have any tumors in the head and neck, if you have disorders with the voice, if there is a cricopharyngeal dysfunction or oropharyngeal problems, or even esophageal problem, then you can score very high. What is more interesting is that it can actually show if the treatment is working or not. And you could see for 3 groups of patients here, patients with reflux, and patients with strictures, and patients with Zenker's diverticulum, the progress after the treatment, you see how the score of the E10 had dropped to just below 5, or just below 5 in 2 groups. With strictures, it remains higher than 5, but it's better than before the treatment. So it's a valid and reliable way of assessing functional pharyngeal dysphagia. The other questionnaire is the Sydney Swallowing questionnaire, and here it's 17 different questions that the patient would have to mark a visual analog scale of 100 millimeters, where 0 is perfectly normal and the other extreme would be having severe difficulty. So the maximum possible score would be 1,700 in here. Anything around 200 or so would tell you that there is a problem with dysphagia, although there is no clear cut. The average for patients, for example, who have neuromuscular problems with dysphagia would be about 800. Now, again, the test can be used to monitor any progress after treatment. So I think if the score moves up and down somewhere around 10%, then this would validate a response to a treatment. And these are the 17 questions used for the Sydney Swallow questionnaire. It used to be 19, but they omitted 2 questions were omitted. How long would it take you to eat a scoop of ice cream, for example? And if there is ever, excuse me, and if there is ever any problem with drooling of saliva. These 2 questions were omitted, so the questionnaire as it is now is only 17 questions, and they ask different aspects about difficulty with fluids like coffee, tea, and water, and thick fluids like custards or milkshakes, and soft food like, for example, jellies and things like this, hard food like steak or raw vegetables, or dry food like bread and biscuit, different things, and adding up the visual analog scale for them. If it's somewhere below 200, and then this passes as near normal. If it's more than this, then the patient would require further assessment. One of the earliest tests for bedside test for this is the repetitive saliva swallowing test, and it's a very simple test that takes less than a minute. You only ask a patient to dry swallow for as much as he can within 30 seconds. Anything less than 3 seconds, than 3 swallows, then there is a problem with his swallowing mechanism. A normal person should swallow a dry swallow more than 3 times within 30 seconds. The good thing about this test, it's very simple. You don't need any resources, and it doesn't entail any risk of aspiration because there is no water swallowed or no dye, and also there is no spilling and no aerosol generation. So it's a good preliminary test. The next test would be the water swallow test. A patient would be asked to swallow first 10 milliliters of water, and if he and if he can manage this, then he would be asked to swallow 30 millimeters of water as a second step. And he should do this within 10 seconds for each. If he can manage to swallow the 10 milliliters and within 10 seconds without any respiratory problems, any coughing, any choking, any respiratory distress, then he would be allowed to have the second step, 30 milliliters. And if he can do this within 10 seconds, then he can be passed as normal. Sensitivity and specificity of this test is not very high. It's around 70%. So, and quite a number, about a third of the patients would be missed by just doing this test. So various modifications were introduced to improve the sensitivity and specificity. And as you can see that swallowing a very small amount of water as a first stage rather than 10 milliliters, you only asked to swallow 1.5 milliliters, could increase the specificity. Because if the patient had difficulty in swallowing 1.5 milliliters within 10 seconds, then the chances that he has something wrong is much higher. And again, you can increase the sensitivity by increasing the amount of water from 30 milliliters to 90 or 10 or 100 milliliters. This would increase sensitivity. So the water swallow test with various modification the sensitivity and the specificity could be increased. Now, pulse oximetry in patients who are hospitalized can be used as well. And if there is a drop in the oxygen during swallowing of some water, for example, or no. If there is a drop of more than 2.5%, this is abnormal. It's not solely dependent on aspiration. And the cutoff point is not validated, but it's a very simple test for patients in the intensive care or hospitalized patient in general. You just monitor the pulse oximetry, and if there's a drop of more than 2.5%, there's something wrong. Why is this not? Now, another test is based on recording the noises generated by the act of swallowing itself. And this actually opens up a whole field of research of analyzing the noises generated by the swallowing act. And as you can see, most of these noises are generated by the opening and the closure of the upper esophageal segments, but also by the movement of the hyoid bone and the movement of the bolus itself within the hypopharynx. But it can be helpful, and it's very simple to monitor this. You can use software on for example, a smartphone, and this could give you the traces in here, and it would mark very clearly the onset and the offset of a single swallow, so you could actually get information about how long does it take a patient to swallow a certain bolus, either a fluid or a thick fluid or a solid, because you have a very clear indication on the onset and the offset with the opening and the closure of the upper esophageal sphincters. And then there is a test. These three tests can be used on patients who don't have much cognitive functions, or patients in the intensive care. You don't need cooperation of patients for this. What you need is to inject through a fine catheter, pass through the nose into the lower part of the oropharynx. You inject a certain amount of water, either 0.4 or 2 milliliters, and see if this could initiate a swallowing reflex or not. A normal response for this, for injecting certain amount of water into the pharynx, within 3 seconds there will be a swallow. There will be a swallow reflex. But if this is disturbed, then there is something wrong with the swallowing reflex. The lower amount of water, the 0.4 milliliter, would have high sensitivity, and the larger amount of water, the 2 milliliters, would have higher amount of specificity. And of course, you could use dyes, like this is the old test we all use to indicate if there is a degree of aspiration through the tracheostomy tubes. Evans blue dye test could be installed into the mouth, either 2 drops of the methylene blue on the back of the tongue, and you wait and see if this could be aspirated through the tracheostomy tube. And if this is happening, then this would suggest that there is a degree of aspiration. I mean, there are various other reasons the dye could appear in the tracheostomy tube, so it's not 100% specific, but it's useful. Now, oops, I've missed the previous one. A modification for the Evans blue test, it was to mix the dye with a certain amount of food or drink, rather than just putting the drops in the back of the tongue. So you could see if the patient would have problems handling thick fluids or purees or custards, or you could actually tell which type of food you could allow this patient in the intensive care, or a patient who have a tracheostomy in the hospital, to manage before allowing them the another type of food if they pass the other test. Now, we move now to the formal assessment of pharyngeal dysphagia by endoscopic examination. This is a 12 steps standard procedure, the FEES test. And it starts with passing the scope through the nose without a local anesthetic, and en route to assessing the upper esophageal segment, you assess 10 other things. So things like velopharyngeal competency, nasopharyngeal, various things, we'll go through them one by one. The very first thing is to pass the scope to the nose and keep the tip of the scope above the level of the soft palate, and watch for the competency of the velopharyngeal sphincter, because sometimes it could be one of the causes of the dysphagia. The next thing is to introduce the tip of the scope a little bit further and scan the hypopharynx at rest without asking the patient to do anything, and without introducing any dyes or so. You will be looking for any abnormalities, any ulcers, any signs of reflux, and measure the baseline number of swallows during dry swallows during a certain amount of period. It should, a normal person should have 3 dry swallows within a minute. Now, again, I missed another one. And then you would go for the pharyngeal squeeze maneuver. And this is a very useful maneuver because it tells you something about the contractility of the pharyngeal muscles. What you'll be doing is you ask the patient to E, for example. And if he does this, this should elicit some lateral pharyngeal wall contractions. If you see this pharyngeal squeeze, it's good news, because it tells you that there is some pharyngeal contractility. And if this is the case, then this patient could manage to eat things like purees or thick fluids. If he doesn't have it, then you should consider nil by mouth until you assess the patient further. The next thing is to look for any signs of secretions or retained saliva in the pharynx before introducing any dyes or any fluids or so. You just check whether there is any retained saliva in the hypopharynx and where. Sometimes you could see saliva in the piriform sinuses. Sometimes you could see it in the vallecula. You wish you wouldn't see it in the laryngeal enteroitus, and you wish you wouldn't see it coming close to the vocal folds. So this would be the 4th step of the FEAS, just checking for any pharyngeal secretions and saliva. Number 5 would be checking for the sensation. Some fiber-optic scopes have a certain channel in it through which you could give puff of air, calibrated puffs of air with certain pressure to elicit reflexes, to elicit an adductor reflex of the larynx or the laryngeal, of the oropharyngeal squeeze when the pressure is exceeds a certain threshold. Most of the scopes don't have this channel, but you can always use the tip of the scope itself to do the same in a more crude way. You could use touch the pharyngeal folds, the tongue, the aryepiglottic fold, the ventricular folds, and try to attest the sensation of the vocal folds as well. And if you touch any of these and don't see a certain reflex, either adduction of the vocal folds or squeeze of the pharyngeal muscles, it may alert you to the possibility that there is a loss of sensation of this particular segment. Number 6 and 7 would be an overview of the larynx itself. You would want to see if there is anything wrong with laryngeal mechanism, and you want to take the laryngeal mechanism to its limits by the people give a very high pitch or very loud noises. You start by observing the larynx at rest and how the patients breathe, and then ask them to sniff to affect maximum abduction, and then to give a cough and see how the vocal folds are ducked, and ask them to hold their breath and count up to 7. Should be most patients should do this with no difficulty. Repeat ha 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 or he 5 to 7 times again to see how the laryngeal muscles move during phonation, and then count from 1 to 10 without taking any further breaths. A strong E with a very high pitch and a strong E with a very loud noise to see the limits of the larynx. And then we start introducing things. And the safest way of starting this is to test the patient with ice chips, particularly if this patient had not had any oral fluids, oral intake for a while, like post-operative, for example. And so it's safer to start with ice chips, because even if they aspirated there would be a minimal risk of causing infection or problems with the aspiration itself. And of course, the ice chips would give the maximum possible stimulation because of the coldness of the ice. But if the patient can manage to have the ice chips without aspiration, if they have aspiration, then you want to see if they can cough up after the aspiration or not, because this is going to help in the grading of the aspiration. And whether the cough up has cleared up completely the ice chips or not. This aspirating without a cough or without complete clearing would be either pass 6, 7, or 8. So it's worth paying attention to see what's going to happen to the ice chips if they are aspirated. If not, then it's safe to take the patient to the next step. And the next step is allowing them to have a colored food or drink. You can start with different consistencies, like thick fluids, like soft food, scrambled eggs, and like or even hard food if the patient can manage to have the softer type of food. Or you could ask the patient to, for example, consume a kiwi fruit. This patient had a kiwi fruit, and you could see the pooling of the food in here and the piriform sinus, and you could see it also pooling in the vallecula. So the actual colored food material, the pooling of it, the residue in different locations would give clues about what is wrong with the swallowing mechanism. The location of the pharyngeal residue. If the location is up there in the vallecula, like in here, then this is usually due to a failure of the preparatory stage, problem in the tongue base, problem in the hyoid, problem in the laryngeal elevation and excursion anteriorly. But if the residue is in the larynx itself, then it's usually due to a failure of the glottic competency. You could see some residue in the piriform sinus in here, and this is usually related to cricopharyngeus dysfunction or delayed pharyngeal emptying. So the location of the residue will help you identify what is the problem. Whiteouts would occur during this type of examination with the scope, of course. And it's useful because it tells you that there is some contraction of the muscle, or the base of the tongue. So it doesn't tell you that things are normal if you see a whiteout. But if you don't see it, you start to question whether the patient's sensation or the motor actions are normal or not. Whiteout are also useful because it times out the swallowing. So if you see a bolus, a residue before a whiteout, this is a pre-swallow bolus. And if you see it up immediately after the whiteout, this is during swallowing. And if you see it a bit or a while after the whiteout, like the accumulation of the residue and the hypopharynx, then this is the post-swallow dysphagia. Now, the 10th thing would be the watching for any penetration or aspiration. Penetration is used here to describe ingress of food or drink down the larynx to the level of the vocal folds. Aspiration would describe the same beyond the level of the vocal folds. So penetration would be up to the vocal folds and aspiration after this. And you could see here various things like incomplete glottic closure. You have the tip of the scope now focus on the larynx. You need to see the epiglottis completely, but you need to watch for what is happening at the glottic level. You see if there is any impaired laryngeal sensation, any reduced movement of the larynx upwards and forwards during swallowing, and any reduced duration of, because everything could be moving well, but only for a very short while before the larynx, there will be an adduction, but the patient would need to open up his larynx very quickly after this in order to breathe again, and this may not be useful if the patient has a delayed pharyngeal emptying. And then it's not difficult to pass the tip of the scope a little bit further from the cricopharyngeus area, the upper esophageal segment, into the esophagus. Some patients with a little bit of encouragement could swallow the tip of the scope and down the upper part of the esophagus. Then you could see if there is any strictures, any signs of gastroesophageal reflux, any signs of Zenker's diverticulum or so. And finally, you would, hopefully by this stage, you would have reached a diagnosis or preliminary diagnosis about what is wrong. And then you could try to see if therapeutic maneuvers could help this patient swallow what he is meant to swallow. Things like various chin tuck, effortful swallow, turning the neck to one side, the supraglottic, various maneuvers could be tried to see if the patient, if the swallowing of the patient can be improved by using any of these techniques. So that will bring us now to the video fluoroscopy. And you use video fluoroscopy, which is the gold standard for the diagnosis of pharyngeal functional dysphagia, in two ways: to assess propulsion dysphagia and also to assess aspiration. Starting with the dysphagia, the use of video fluoroscopy in dysphagia. You would want to see how the bolus flows into the hypopharynx, and if the timing and the pattern, and if there is any spillover into the larynx or over to the nasopharynx. And there are various grading systems. For the aspiration, we use the PASS, and for the propulsion, the dysphagia, we use the pharyngeal residue, the bolus residue scale. We'll see examples of this. But first, the frame that we use to assess the degree of the dysphagia is the swallow rest frame. This is the end of one act of swallowing and immediately before the other swallowing starts. We'll be looking for this point in here, the lowest part of the piriform sinus, the piriform sinus, in relation to the cervical column, and this would be taken as the frame, the rest frame. When it reaches the lowest possible point, this would be taken as the swallow rest frame. Now, this is a normal video fluoroscopy. It shows that the patient could handle the balls well. There is no regurgitation into the oropharynx or the nasopharynx, and no spill over into the larynx, and the bolus had passed the hypopharynx promptly within a second, so that's normal. But in here, you would see that some of the bolus would stay around after the end of the swallowing, and this time it chose to stay in the vallecula. This is one of three places where the bolus would choose to stay in the hypopharynx. this is a bolus in the vallecula. And here the residue had stayed in the piriform sinuses in here. The third area would be in the middle part of the pharynx over the posterior pharyngeal wall. Now, there are various scales to grade the amount of dysphagia using the video fluoroscopy, but by far the commonest, the easiest of them is the bolus residue scale, which would grade the dysphagia between 1, where there's no residue at all, and 6, where there's maximum problems. And the grading here depends on whether or not there is any residue in the 3 possible locations: the vallecula, the mid-pharyngeal segment, that's the posterior pharyngeal wall, or the piriform sinus. So no residue would be 1. If there is only a bit of residue in the vallecula, like in here, this would be 2. If there is a residue in the posterior pharyngeal wall or the piriform sinus, then this is 3. If there is residue in the vallecula and 1 of the other 2, this is 4. If there is residue, 5 is if there is residue in the posterior pharyngeal wall and rather than or the piriform sinus. And 6 would be if there is residue in the 3 spaces in vallecula and the mid-pharyngeal part and the piriform sinus. So it's reproducible and it's very reliable, and it has been validated. It's a good way of grading systems, and the intra and inter-reproducibility is almost perfect. The good things about it is that if experts are using it, they would agree almost always in the grading. But even if non-experts are using it, like medical students or nurses or doctors who don't have enough experience with this grading, they would still give you a fair agreement, even though it's not perfect like in the with the professionals. It's still quite 75% is not bad. And the other thing is that even when they disagree, they only disagree by 1 stage, the up and down the scale, so they don't get it too wrong. But there are other ways of grading the bolus residue, a little bit more complicated. They are being developed. It's worth just mentioning it because possibly the future would be this ways of quantifying them by pixels and using artificial intelligence to give results rather than grading them by visual perception. The various ways of scoring includes comparing the amount of the residue to the whole space in which it resides. Like you can compare, for example, the length of the residue in the vallecula to the whole of the length of the vallecula, or the width of the residue to the whole of the width of the vallecula. Different schemes for this, like, or you could multiply the 2 together. You can get another scheme, or you could see if you could compare the amount of the residue compared to the initial bolus itself. You could measure the size of the bolus and compare the residue to it. This is the one advocated by the Digest group. Or you could use this pixel-based methods in which you would compare the amount of the pixels retained in a certain space, the vallecula or the piriform sinus, to what you would expect the number of the pixel in that space if it's full up. So this would give you the percentage full scheme, or you could compare it to a certain other frame, like the volume, the distance between the end of C2 and C4 squared. So you get this ratio between the pixels in a space to the pixel that could have filled up the space in relation to this, and in relation to a certain landmark that you can measure as well. Possibly in the future there will be some progress down these 3 lines in here if if they are refined a little bit more. Now, the timing of the penetration is also important. What makes the when does the penetration happen would help in identifying whether the aspiration is a pre-swallow or during the swallow or after the swallow, like we have seen with the fees, for example. And the same reasons. Pre-swallow would be impairment of the handling of the bolus in the oral cavity or a delay in the swallowing reflex initiation. Aspiration during the swallow would be due to laryngeal rather than pharyngeal problems, or sometimes pharyngeal overflow. Aspiration after the swallow is usually due to a problem in the upper esophageal sphincter or a sensory deficit in the larynx and the laryngopharyngeal segment. And finally, we move to the way of grading the video fluoroscopy, the aspiration by video fluoroscopy. This is the 8-point penetration aspiration scale. And it's a very, again, it's a very useful way of grading and been validated. Various modifications have been added to this, but it is validated and it is reliable. It grades the aspiration and the penetration according to the depth of the aspiration down the larynx, whether it's hold up in the supraglottis, the glottis, or the subglottis, whether there is any attempt at coughing it up, or whether there is any clearing, complete clearance or not. So it's 8 different scales, where number 1 is no problem at all, and number 8 is that the aspiration, the patient would aspirate all the bolus below the vocal folds and no attempt at ejecting it at all. In between 1 and 8, there will be 6 different grades, 2 of them for the supraglottis, which the aspirate would pass into the supraglottis, but above the vocal folds. In 2, it would be cleared, ejected from the airway promptly, and 3, it would not. And then 4 and 5 would be the aspirated material would touch the vocal folds, again 4 and 5. 4 would be cleared promptly, 5 would not. And 6 and 7 would be it passes down the level of the vocal folds. In 6, it would be ejected completely. In 7, it would not, but there would be a cough reflex, but it would not be completely ejected. In 8, there wouldn't be any attempt at clearing it at all. So just quick examples of these. This is pass number 1, which is normal. The bolus is swallowed well with no evidence, nothing at all passes into the airway. And number 2, it's now considered normal because it's very common to see it in normal subjects. This is just a flash as penetration, just a little bit of the dye which dips into the laryngeal interaortus, but it's promptly cleared by a cough reflex. So it's no longer, number 2 is no longer abnormal. Number 3 is different. The dye would go into the supraglottic space, but does not trigger any immediate swallow reflex. So it would linger around for a while. You can see how the dye here is staying above the level of the arytenoids in there. Remains above the level of the vocal fold and is not ejected completely. It is a question here, the integrity of the laryngeal sensation, the superior laryngeal nerve, the internal branch of the superior laryngeal nerve, because the dye could reach into the supraglottis without exciting any cough reflex. Number 4 is rare, in which the dye would dip a little bit further from the supraglottis, touches the vocal folds, but then is completely cleared. They have a very prompt response. So you could see how the dye dips down the supraglottis, touches the vocal folds, but is cleared. You can see it here. And then very promptly cleared. It's rare. Number 5, the same would happen, but this time it's not going to be ejected. It would stay just above the vocal folds level. You see the arytenoids here, and you could see the dye just above the vocal folds. So it wasn't sensed by the supraglottis, and it's not sensed by the vocal folds itself, and you start to question the sensory, the integrity of the sensation of the supraglottis and the glottic level, the internal branch of the superior laryngeal nerve, and the sensory branches of the recurrent laryngeal nerve as well. Number 6 is exceptionally rare. There would be a penetration and aspiration. Some of the dye would go down the level of the vocal folds, but it would be coughed up quickly. So you can see the dye here down the level of the vocal fold, but it would be cleared completely. And if it's cleared completely, then this is number 6. Number 7, the dye would again penetrate into the supraglottis, aspirated below the level of the vocal folds, and there would be a cough. There would be an attempt at clearing this dye in there, but this attempt is not very effective. So a certain amount of the dye is going to stay around. This is number 7. And number 8 is silent aspiration. You would see how the patient would get all the dye down his airway, down the trachea, or even the bronchi. No attempts at coughing, no attempts at clearing the airway at all. The dye would just pass directly down the airway. There is a good agreement between video endoscopy and video fluoroscopy and the diagnosis and the grading of various problems with pharyngeal dysphagia. The video endoscopy is a fairly safe procedure. The incidence of estaxis is next to 0, and the incidence of airway compromise is also next to 0. And it can be, the agreement could reach more than 3/4 of the cases for pharyngeal propulsion, for the dysphagia, and higher for patients with aspiration. So they actually complement rather than compete. They add more information. Some of them would be more useful in some patients, like the video endoscopy would be more useful in, for example, as a bedside or the intensive care rather than doing a video fluoroscopy. Of course, FEES is a little bit more, is more utilized in care facilities. It's a little bit invasive, but as I say, it's very safe. So by this, we come to the end of this presentation on the functional pharyngeal dysphagia, the assessment of the functional pharyngeal dysphagia. Thank you very much.
Thank you, Professor. Before we finish, I need everyone to write his email if they want to get the certificate for attendance. And anyone wants to ask Professor questions, he just can unmute himself and just ask directly.
Can I?
I can't hear you.
Right. Quick question.
Sure.
Thank you very much, sir, for your talk. I just wondered if you have patients with cricopharyngeal incompetence, say at the level of the palate, do you treat them in your team or you refer them elsewhere, say to Max Fax or other specialty? Cricopharyngeal incompetence causing swallowing or associated with swallowing difficulties and say speech. Do you usually treat them within your team or your service, or you refer elsewhere?
Oh, yeah.
Thank you.
Oh, yes. I think we are better placed to deal with this type of problems than other disciplines. We usually start with, for cricopharyngeal dysfunction, we usually start with Botox injection and repeat it. And if there is a good response, but if there is a recurrence of the symptoms quite often after a few months from the injection, we may consider doing a myotomy either endoscopically or externally. But I think we are better placed actually to do this type of surgeries or assess the patient than other disciplines.
Thank you.
Thanks. So Mr. Salama was raising up his hand as well. Anyone else?
Yes, Prof. First, I'd like to thank Mr. Riyad, and I'm very grateful to hear his voice, and I hope you are okay. So a long time I haven't seen you. Thanks a lot. We always owe you a lot, learning, teaching, and training. Thank you very much. This one thing, because you touched on the questionnaire regarding the dysphagia, you mentioned that the score very high with the possibility of cancer. So, my question is, would we depend on that in assessing excluding cancer, or and including the fees and including the barium swallow, or the proper way is to have visualizations through an OGD? And this, I believe, is a big teaching point here. Thank you.
Yes, thank you for this. These questionnaires are meant for screening of patients. They are very quick ways of screening patients for difficulties. They don't hint at any specific diagnosis or any specific problem. So if you score more than 3 with the EAT-10 or more than, say, 200 with the Sydney questionnaire, then you require further assessment. You require to have a FEES, or you could require to have a video fluoroscopy. And this is going to examine what is wrong and why this happens. The fact that you can score very highly if you have a certain tumors, for example, does not make it a good way of assessing, of screening for tumors. It's just a questionnaire for assessing difficulty with dysphagia as a very preliminary step.
Professor, anyone else that wants to ask a question before we leave? I think so. Everyone is tired at the moment. It's the end of the day. Thank you for all of the attendees, and make sure that you've put your emails to in the comments so we can send you the certificates. And really appreciated your input, Professor Magdy, and we hope to see you soon in another interest topics. Thanks, today was really interesting, and a lot of participants as well are there, I think, so because they are interested in the topics. So have a nice evening, everyone, and see you later. Thank you.
Thank you very much. Thank you. Bye-bye.